dose of Valium or Versed you can give me at a single time?
Five.
So you wouldn't give a kid more than 5. All right? If you wouldn't give me more than 5, don't give a kid more than 5. So any kid over 10 kilos, the max amount of Valium they can get is what? 5. Doesn't matter if we do the math and they need 10 milligrams, we're going to stop at 5. We're not going to give them all 5 at once. We're going to give them a milligram, wait 1 to 2 minutes, give them another milligram, and either stop season or we reach our max of 5. Okay? Don't give them all 5 at once because you'll snow them. If they have active diarrhea and the Valium will not stay in, or the parents have already tried rectal Valium, like a benzo because the kid has a history of seizures, and it's not working, then we'll try IV. IV, we cut the dose in half. It's 0.2 milligrams per kilogram to a max of 5. Rectal is preferred because of decreased respiratory depression side effects, and we can get it on board quicker because we're not trying to start an IV.
Said 0.25?
0.2. Highlight those two. Highlight 0.01 milligram per kilogram of Epi 1 to 10,000. That's your that's your pediatric full arrest dose of Epi, 0.01 milligrams per kilogram of 1 to 10,000. Highlight that. Highlight adenosine, 0.1 mg per kg. Under the 0.1 milligram per kilogram column. Highlight adenosine. And then below that, put 0.2 mg per kg. So here's what it is. The first dose is 0.1 milligram per kilogram to a max of 6, because that's what you would give me the first round, correct? The second one is 0.2 milligrams per kilogram to a max of 12. Yesterday, when we did cardiac algorithms, if I had SVT in an adult, I went 12 lead vagal, adenosine, 6, 12, and 12. If I have SVT in a kid, 12 lead vagal, adenosine, 0.1 mg per kg to a max of 6, 0.2 mg per kg to a max of 12. All we did was adjust the dose of adenosine to the kid's what? Weight. Yesterday, if I had unstable SVT, I did what to the adult? Cardioverter. So what am I going to do to a kid if they're unstable? Low BP, altered LOC, severe chest pain, shortness of breath, unresponsive. So if I have unstable SVT in the kid, I'll cardiovert. But I'll use 0.5 to 1 joule per kilo instead of a fixed dose like I did yesterday. Yesterday in VFib, I CPR and shocked as soon as possible. In a kid, CPR shock as soon as possible. But I'll use 2 joules per kilo instead of a fixed amount like I did on the adult yesterday, because remember, everything in a kid is weight-based. So I would highlight the pediatric cardioversion, 0.5 to 1 joule per kilo, and I would highlight defibrillation, 2 joules per kilo to a max of 10.
What's that 4 joule thing?
What's the 4 joules?
I tried 2, then I tried 4, and I can go to a max of 8.
Oh.
So I tried 2, didn't work. I tried 4, doesn't work. I can go all the way up to 8.
Did you say 10?
10?
To 8 to 10, yes.
Kill.
Right. Right.
You want to teach him?
I could try 2, 4, 6, 8, but I can't go above 10. 10's the max. So, another college level question. You have a 7-year-old. What is your max asynchronous cardioversion setting? What does asynchronous or unsynchronized mean?
Defib.
Un or a means not syncing. When I teach in New York, they always tell me I talk funny because I'll say shock them, and they're like, "What?" I go, "What do y'all do? We do's or we don'ts hit the sinks. They do's got a pulse, we do's hit the sinks. They don'ts got a pulse, we don'ts hit the sinks." And then they tell me, "You listen funny, we don't talk funny." And I'm like, "I don't understand anything you guys say." So if they don't have a pulse, we don't synchronize cardioversion. So this is asking you the max you can defibrillate this kid. Well, they didn't give me anything. I know the max is 10 joules per kilo in a pediatric.
2 kilos.
So now I have to take 2 times the age, which is 7, plus 8. So that's 2 times 7 is 14 plus 8. That's 32 kilos.
22.
22. 14 plus 8 is 22. So this would be 10 times 22. So the max is 220 joules. Once again, I would only be able to figure that out if I had my what? Formulas. You are going to see 1 to 2 pediatric drug questions, 1 to 2 pediatric algorithm questions, and either a cardioversion or defibrillation energy setting. They just want to know if you can do the bare minimum. Could you shock a kid in VFib if you had to? Could you cardiovert a kid in SVT if you had to? That's all they're wanting. All they're jacking with me. What happens if somebody walked in that door right now with a limp kid? We're expecting to what? Perform. And that's why they ask this question. Yes, sir.
Is there a max on cardioversion?
Same as adult, or not same as adult, same as defibrillation 10. You would start at 0.5 to 1, and you would keep going up every couple of minutes until it either worked, or they died, or you got to 10 joules per kilo. Highlight Ativan. I told you all be ready for 0.2 milligrams per kilogram of Ativan, possibly in next week during your scenarios. Ativan can be given IM or IV. It cannot be given intranasally or rectally. IM or IV. If you can't give an IV, give an IM. Amiodarone, 5 mg per kg to a max of 150. If you had VFib in an adult, CPR shock, epi shock, amiodarone. If we have VFib in a kid, CPR shock, epi shock, amiodarone shock. Except that epi and the shocks and the amiodarone will be based on the kid's what?
Wait.
It's the same algorithm.
Will it be 150, 150?
Yes. But they ain't going to go that far. They're going to say, you have a 7-year-old in VFib, what antiarrhythmic should you give? And they'll ask you the dose of like amiodarone. All right? Once again, it's just meat and potatoes
5 milligrams per kilogram.
to a max of 150.
What about the VTAC with the pulse?
Amiodarone, 5 milligrams per kilogram over how many minutes?
10.
10.
Okay.
Or you could give lidocaine, just like we did yesterday.
Yeah.
Lidocaine's the exact same as the adult dose, 1 to 1.5 mg per kg. You are going to see a couple of pediatric algorithms. It's okay, just remember it's weight dependent. It's weight dependent. If you would do it in an adult, do it in the kid, but don't exceed the adult dose of electricity or meds. How do we treat asystole yesterday? CPR, IV, airway, epi, H's, and T's. How do we treat it in a kid? Exact same. Except our epi's weight dependent. All right? Remember, all IOs go on a 60 or on a 10 drop set. IVs in kids go on a 60. You may see a specialized pediatric IV set called a Buretrol or Burette. And it's basically a long drip chamber that has mil marks on it. So instead of being a regular IV drip chamber, it will hold up to 200 cc's, and they're about that long. They're used in specialized pediatric to where if you needed to give 100 cc's, instead of eyeballing the bag down, you can fill that drip chamber to exactly 100 cc's, turn the bag off, and run it in. It's called a Buretrol or Burette, all right? And the only reason why I put that on there is because every once in a while they'll say, you're transporting a kid on an IV and he has a burette. You are to figure out how much fluid you're supposed to give the kid over the next 30 minutes using a burette. How many drops a minute's that? Well, a burette is a 60 drop set, and it's just like a PD. It's just it has a big drop chamber. So that's where that question came from. It's also called a Buretrol. All right? That should do that for that page. We've already covered the next page. Move over to where it says laryngeotrachea bronchitis. Laryngeotrachea bronchitis is the viral name of croup. It should say pediatric diseases and terms. Highlight laryngeotrachea bronchitis for the viral name of croup.
Wait, where are we? I'm sorry. Lost.
Go 3 more pages back in the pediatric drug package. Maybe 5 if you're single-sided. So, highlight laryngeotrachea bronchitis, the viral name of croup. Highlight viral. Next to parainfluenza, write type A. Highlight 5 down from there, cold progressing to hoarseness. Highlight low-grade fever below 101. Highlight nighttime increases edema. And then your stridor, barking cough. Highlight recurs on several nights. And then highlight your management. Humidified oxygen, IV if tolerated, racemic epi, and highlight anticipate the needs to intubate. Now let's compare that to epiglottitis. Epiglottitis, highlight bacterial. Croup was viral. Next to hemainfluenza, write type B. Croup was type A. Under croup, under epiglottitis, highlight 5 down from there, respiratory distress, sore throat, drooling equals epiglottitis. Highlight fever greater than 102. Highlight was not sick when they went to bed. Croup was sick all day, worse at night. Epiglottitis wasn't sick at all. Highlight no barking cough. Your treatment for epiglottitis is humidified oxygen and do not look in the airway. So we have opposite things here. Croup viral, flu type A. Epiglottitis bacterial, hemainfluenza B. Croup sick all day, worse at night with a barking cough. Epiglottitis is not sick at all, wakes up in the middle of the night, fever, sore throat, drooling. Croup has a fever below 101. Epiglottitis has a fever 102 or greater, yes.
You want to make sure with epiglottitis that you don't piss off the kid, right?
Correct. Croup, give them humidified oxygen and racemic epi and be ready to put a tube in their mouth. Versus epiglottitis, don't touch the kid. Don't piss him off. Only do blow-by oxygen if tolerated. Don't try and look in their mouth. So I got one I want you to be ready to tube, and I got one where I don't even want you to look in there. Complete opposite presentations. You are going to see 6 to 10 questions on this typically. You have a 3-year-old barking cough all day. You suspect parainfluenza A, parainfluenza B, hemainfluenza A, or hemainfluenza B. Well, if he has a low-grade fever, coughing all day, worse at night, he's what? Croup. And what flu caused croup? Parainfluenza A. That's how they got that question. You have a kid with high-grade fever, drooling, you suspect viral or bacterial? Bacterial. You have a kid cyanotic, turning blue, with a viral infection and a low-grade fever. You suspect epiglottitis, hemainfluenza B, laryngeal tracheal bronchitis, or paratonsillar abscess.
Bronchitis.
Laryngeal tracheal bronchitis, which is the viral name of croup. You have a 4-year-old, wakes up in the middle of the night, high-grade fever, stridor, and drooling.
Epiglottitis.
Wakes up in the middle of the night, high-grade fever, drooling, epiglottitis.
Is that
Even influenza B or
Yes.
parrot?
Even influenza B for epiglottitis. Parrot influenza A is an Adam recruit. There they are down there on the bottom page again. Learn the differences. Viral versus bacterial, A versus B, low grade fever versus high grade. Barking cough, get ready to intubate. No cough and drooling, don't look in the mouth. Learn the differences. Does that make sense? Next page, pediatric assessment triangle, pretty self-explanatory. The stages of labor. Earlier we talked about early and active. We're going to break it down a step further. If she's contracting, she's stage 1. Stage 2 is from crowning to clearing the mouth. So if she's crowning, she's stage 2. If it says you just suction the mouth, we are stage 3 now. Crowning is 2. As soon as you can suction the mouth and the nose, we have moved into stage 3. That's why it says clearing of the head. As soon as you can suction the mouth, we're in stage 3. Stage 3 ends with the delivery of the placenta. So, 37-week female, she says the baby's coming and she has bulging perineum. What stage are you at?
1.
Bulging perineum means crowning. She's bulging. That's crowning. Bulging is crowning. That is stage 2. If she's having contractions 7 minutes apart,
Stage.
bulging 2, you have just suctioned the mouth, you were in stage 3. Stage 3 ends with the delivery of the placenta. We don't typically deliver placentas in the Viatel system because of our transport times. All right, it's not real common. If the placenta does deliver, put it in a bag, take it in. There's a biohazard bag in the OB kit. Put it in that so they can weigh it, do some tests, and make sure the health of it, those type of things. I don't know, maybe mom will want to save it for down the road, whatever. There's all kinds of things that happen now, but do not pull on the umbilical cord to try to deliver the placenta. If you pull on the umbilical cord, you can tear the umbilical cord, or you can cause a uterine inversion or uterine rupture. So don't pull on the umbilical cord. I know they did at the labor and delivery, but we're not doing that. We're going to let it deliver natural. And usually it's going to occur anywhere from 5 to 15 minutes after the delivery of the child. If, once we deliver the kid, if she's still distended and looks pregnant, there's probably twins. If she's soft and squishy, that's good. If it's rock hard, hurting, and she has a lot of bleeding, that's usually a uterine rupture. So, soft, squishy, little bleeding, that's what we want. All right? What will we do to help the uterus contract back? Fundus massage, put a sanitary napkin. We're not going to put anything inside. And then we're going to have a breastfeed. Breastfeeding causes what chemical to release? Oxytocin, which is also called Pitocin, which will cause the uterus to contract back. Fundicide. From the top of the pubis bone to where we return back at the xiphoid, the amount of centimeters of growth should correspond with the amount of weeks pregnant. So roughly about 12 weeks, she'll have a 12 centimeter fundus and she will start to show that she's pregnant. This fundus height will give me some data. All right, we're not actually going to measure her back at the ambulance, but it will give us some data. If she is 38 weeks pregnant with a fundus height of 20, so she's fixing to deliver and you can barely tell she's pregnant. What does that tell you about the weight of the baby? It's really small. That's an easy delivery. But you need to have what equipment ready?
Innovation.
Airway stuff. Because the last thing to develop on the baby is its lungs. And if it's that low birth weight, its lungs aren't going to be fully developed. So you need to be prepared, easy, quick delivery, but anticipate the needs to ventilate and intubate because the kid's lungs aren't fully developed yet. Does that kind of make sense? Now, if I said she's 37 weeks pregnant with the fundicide at 35, that's almost perfect. That should be a normal delivery and a normal kid, because it's where it's supposed to be. As long as she's within 5 to 10 centimeters, we're okay. We should expect a normal delivery and a normal kid. It's when it's way low or way high. She's 37 weeks pregnant with the fundicide of 50.
Big baby.
That's like,
Yeah.
that's,
Twins usually will fall within that 5 to 10 centimeters. She's has what pregnancy disorder? Gestational diabetes, which led to a fathead 5000. That kid is so big and so developed, it will not deliver vaginally more than likely, so we shouldn't attempt it. We need to take her in for cesarean. The kid's developed and lungs are developed, but it's too big to deliver vaginally. She needs a cesarean. Twins, if you think about twins, most of the time, the average weight of twins combined is about 10 pounds or less. So that fundicide would still be within 5 or 10 centimeters, because remember, I don't have one giant baby, I got 2 little ones. So their fundicide would still be within 5 or 10. Now, if you deliver and it's still distended, there's another baby in there. Yes.
So this might seem like a dumb question.
It is.
Where is this measured from?
Pubis bone to the top of the xiphoid.
Okay.
So that's why they take the tape measure and come back. You married?
No, I mean, I am, but I'm not having any kids.
Oh, okay. If any of y'all have ever gone to a doctor's appointment when she's pregnant, they measure her every time, using just a soft tape measure, check the blood pressure. Halfway through, they'll do a diabetes test to make sure they haven't developed gestational diabetes, and those are all the reasons why.
Isn't the twins usually like 30 minutes apart or something?
They're at the most, they're 30 minutes apart.
Okay.
At the most.
depends on, yeah. Mine were 3 minutes apart.
Yeah, mine were about 8. 8 minutes apart. I think one was born at 5 afternoon or 5 after 1, and the other one was 8 minutes later. So that's what the fundus tells us. Braxton Hicks is false labor. It's usually painful or painless. They feel it contracting, but it doesn't hurt. Dehydration can cause it. Have them get up, walk around, give them some IV fluids. That will usually help. Signs of imminent delivery: if she feels the baby's crowning, she has the urge to push, have a bowel movement, contractions are less than 2 minutes apart. Those are all reasons to pull over to stop the ambulance. Contractions are measured start to start and start to stop. All right? So she started having a contraction right now at 14:58. And the next contraction started at 1500. And we started at 14:58 and it stopped at 14:59.
Game time.
It's about game time. We would report this start to start. She's 2 minutes apart. Start to stop is 1 minute in duration. So her contractions are 2 minutes apart. They last a minute. So she's barely going any time before she starts contraction again. That's almost continuous. Pull over, prepare to delivery, stop the ambulance.
Okay, I was gonna ask you, at what point did the bridges
Yeah.
come off?
We should look before we put them back in the ambulance.
Okay.
We want to check for crowning prior to. If her contractions are speeding up to this point, pull over, prepare for delivery. If she starts to crown, she starts to feel like the baby's coming and she needs to have a bowel movement, those are all signs. Pull over, stop, prepare for delivery. The reason why we pull over and stop, prepare for delivery, because we're going to need an extra set of hands back there to help clamp, cut, and dry. All right? After we deliver the kid, we're going to leave the kid level with the vaginal opening. We don't want to Simba the kid, put it way up high, because all the blood will run back into mom. Nor do we want to put it low. So we want to leave it roughly about the height of the belly. We want to clamp and cut the cords. The biggest thing is make sure you leave at least 2 inches or 6 centimeters. So we got mom going to baby. All right, umbilical cord. You want to make sure that you have a clamp at least 2 inches above the baby. and another one at least 3 inches above the baby. All right? Or 6 centimeters and 10 centimeters. The reason why I want to leave at least 2 inches of umbilical cord between it and the clamp is in case we have to do an umbilical IV catheter, it doesn't go into the stomach. So leave at least 2 inches of umbilical cord before we cut it. We don't want to cut it too short. The other problem of cutting it too short up against the kid is it's harder to clamp. So I place my clamps 2 inches and 3 inches above the baby. No pulse, cut it. If there is a pulse, my clamps aren't tight enough, I need to reclamp them. Once we cut it, we're going to suction the kid's mouth and nose. We're going to warm it. We're going to dry it. And we're going to stimulate it. Rub the soles of its feet, its back, flick its feet, get that kid moving. If the kid starts to move and the heart rate's above 100 and the extremities are blue but the body's pink, we'll do some blow-by. If the heart rate's below 100, then we will start ventilations. If the heart rate falls below 60, or after a minute of ventilations it's still below 100, then we'll add compressions. After 1 to 2 minutes of ventilations and compressions, if the heart rate is still low or there is no pulse at all, then we will intubate. If intubation doesn't get the kid's heart rate up, then we'll medicate. Epi 0.01 milligrams per kilogram at 1 to 10,000. So we're going to warm, dry, suctionize, stimuli, blow by. If it's bradycardic, we'll ventilate. If ventilations don't work, we'll compress. If compressions don't work, we'll intubate. And if all of that has failed, last ditch, we'll medicate. And do not forget to check a D-stick in them. If they are born and their pancreas isn't working, or they have a metabolic disorder, their blood sugar will be low. We may have to give them some sugar. All right? Check a D-stick in them as well, if they're altered. If they're active, crying, that's good. All right? They'll check their sugar when they get to the hospital. But if they're lethargic, not coming around, and we've done all those things, don't forget to check their sugar. Gravida is how many times pregnant. Para is pairs of feet hit the ground alive. Me and my ex-wife are Gravida 2, Para 3, no AVs. So we were pregnant twice, have how many kids? 3. So I have a set of twins. One of the guys I work with, him and his wife are Gravida 3, Para 3, and they had 2 miscarriages. So 3 pregnancies, the first 2 miscarried. So 1 pregnancy related and 3 kids, they have triplets. And one of his kids is now on the fire department. Him and my son hired on together.
That's gotta be confusing.
It is.
Canceled out. Little petri babies.
No, they weren't Petries. All right, so that's Gravida and Para. Antepartum's before, postpartum's after. Grand multi's a lot. Eclampsia, what happens in eclampsia is she has excessive protein production because of a hormonal change during pregnancy. That excessive protein, just like when somebody goes into DKA, that excessive protein did what to the kidneys? It clogs them at the tubulars. That excessive protein starts to clog the kidneys. It makes her retain water and trash. If she retains water, she retains sodium, which makes her retain potassium. As a result of retaining the water, her blood pressure starts to spike. She starts to have excessive pedal edema and excessive water weight gain. Now, normally in the 3rd trimester, what we expect to see is we expect her to go from 5 liters of blood to roughly 6.5 liters of blood. Normally in the 3rd trimester, in order to transport this additional blood, she will vasodilate, which will make her temp go up. And if she vasodilates, it will make her blood pressure go down. And I would expect the blood pressure between 90 and 110 systolic. And I would expect a respiratory rate of 20 to 28. And I would expect a heart rate of 100 to 120. This is normal in the 3rd trimester. What is not normal is a pressure greater than 140. If it is greater than 140, she is shoving all this additional fluid through those kidneys and overloading her kidneys. That's what causes them to start to clog, and it leads to the excessive weight gain and hypertension. Well, if she's not taking out the trash, she's retaining sodium. If she's retaining sodium, she's retaining potassium. Yesterday we talked about sodium and potassium is what makes all of your nerves and muscles fire. So if she has elevated sodium and elevated potassium and it starts moving in and out faster than the nerves and the muscle can interpret it, those muscles are going to start spasming uncontrollably, which is tonic-clonic seizure. She's having eclamptic seizures now because her sodium potassium is elevated and moving too fast. How do we slow down
Mag.
the sodium potassium pump? MAG. That's why MAG, her registry, is the drug of choice for eclamptic seizures. If her pressure is greater than 140/90, or her systolic and diastolic rose a bunch during pregnancy, she's preeclamptic. When she starts to seize, she's eclamptic. MAG resets the sodium potassium pump, and it's a smooth muscle relaxant, so that's going to help stop the seizures because it's not a brain seizure, it's electrolyte toxicity. The problem is if she starts seizing, contracting, and she starts to tear her cervix, and she starts to deliver the baby premature, the last thing to develop on the kids is its lungs. So she's trying to deliver this baby prematurely while having a seizure, you give it MAG. What else can MAG work on besides torsades and eclampsia?
Asthma.
Asthma. Status asthmaticus. What does it do in asthma? It bronchodilates and relaxes the lungs. What's the last thing to develop on the kid?
Lung.
And you just gave him a drug that relaxes lungs that aren't developed yet.
Not good. Good night.
And she has hypertension, and she tore her cervix, and she has more blood, and she's tachycardic. She's going to be like a stuck pig. You are going to need somebody to take care and probably intubate the kid in back of the ambulance, and you're going to need somebody to manage hemorrhagic shock in mom because she's bleeding to death. High chance of mortality for both mom and baby if she starts seizing. If you run on somebody that's preeclamptic, high blood pressure, excessive weight gain, try to keep them calm. Talk to them softly. Try not to throw them around the back of the ambulance. Take extra help with you because if something goes wrong, you're going to need someone to help you manage her and 1 to 2 medics to help manage the baby. Children's has trained their transport nurses to go pick up these kids from other ERs, or I should say moms, that are preeclamptic, and they've trained them to go pick up these high-risk pregnancies and take them back to Children's or Parkland to where if she does start to seize, they have all the experts in neonatal care to take care of that baby, and they have surgical capabilities to take care of mom. They are very high risk, right? Very high risk. Real world, keep them calm. Have your Versed ready because here's why we're not going to give MAG in Biotel. It's 1 to 2 grams over 10 to 20 minutes. By the time we get it set up, we're pulling in the ER. So if they start to seize, we can give them Versed. But for testing purposes, they want MAG. All right? They want MAG. Do we understand how eclampsia develops with the clogging of the kidneys and the acidosis and the retention of sodium and potassium, why we end up giving it MAG?
But we don't give MAG until they're actually seizing.
Correct. We're not going to till they start to seize. They can also develop eclampsia post-delivery for 3 to 7 days after.
Yeah.
So, once again, if she has hypertension, delivered yesterday, she's actively seizing today, pressure's through the roof, that's postpartum eclampsia. They can still have those hormonal and kidney issues a couple of days after delivery.
So MAG would only be given for like a long transport time?
Per testing, you're going to give it to every eclampsia.
Oh,
Here in the Metroplex, we're not going to have time to get it going.
okay.
Vaginal bleeding, pretty self-explanatory. The key on the vaginal bleeding is if she's using more than one or two tampons or pads an hour. The average tampon and the average maxi pad or feminine product or feminine napkin, which is what they'll call it on the registry, will hold 60 to 80 cc's of blood. Well, if she's using more than 2 of those an hour, she's losing over 100 to 200 cc's of blood an hour. That's not normal. We need to transport her. Those causes are pretty self-explanatory of why they have vaginal bleeding. If they do have an external laceration, have her put direct pressure on the skin. We're never going to pack anything inside of it. If we can get a female medic to do it or go with us, we should. All right? If it's a sexual assault, tell her not to urinate, tell her not to shower, encourage her not to wash her hands. If there is fibers or fluids on clothes, the clothes go in a paper bag. If she has a handful of hair from the assailant, that goes in a Ziploc baggie. All right? Clothes and fluids go in a paper bag. Hair goes in a plastic bag. The reason why we don't put clothes with liquid on them, whether blood, semen, whatever, they don't go in a plastic bag because the plastic bag, the chemicals deactivate the DNA. The paper bag will absorb it, but it won't change the DNA. So make sure that we don't have them shower, don't wash their hands, don't wash their hair, and if you do end up having to collect evidence, clothes and liquids, paper bag, handful of hair or fibers, plastic bag. All right? Usually, though, we're just going to put it on their lap and try not to disturb it, but the book asks that. All right? The registry sometimes asks that. What do you do with evidence? Blood and liquid, paper bag, fiber, plastic. All right? Page 6, amniotic fluid or sac. If it says BOWR, that means the water has not broke. Gently tear it with your teeth. Just if you're awake. All right? Carefully tear it between 2 fingers. Usually between your gloved hand will end up letting it tear. Is BOWI, BOWR, it's already ruptured. If it's ruptured before we get there, we're going to find out. If it was clear or light yellow urine color, that's good. We want to make sure there wasn't any blood or meconium in it. Page 7, middle smirts is painful ovulation. This is a distractor for a topic. The key here is it happens every month, 7 to 10 days after her period, and it's painful ovulation. She has large eggs that move through her fallopian tube. Now, it does increase her risk for ectopic, but the key here is last period was a week ago and was normal, and she's had this pain before. Versus last period was 6 weeks ago, and it started with jogging. Middle spurts, she has that pain every month. If you've ever dated a girl with middle spurts, you know that when she's ovulating, she'll have to lay on the ground, the bed, put a heating pad on it. It's extremely painful. It also increases the risk of ectopic. But key here is, happens every month, 7 to 10 days after her last period. Versus 6 to 12 weeks, cool tail clammy after jogging was ectopic. Nothing we can do for middle smirts. Dysmenorrhea is basically bad menstrual cycle. Ectopic pregnancy, nothing we can do for it. Endometriosis is a cyst. It's extremely painful, and when it ruptures, it's immediately relieved because it's no longer having fluid pushing the skin out. So if she says, I was having sharp stabbing pain, I felt a pop, and now I'm better, that's a endometriosis. It's a cyst. All right, and it's not uncommon for women to get cysts on their fallopian tubes. The key there is if ruptured and now they feel 100% better, that's usually a cyst. Endometritis is sepsis infection that occurs 3 to 7 days after a child delivery or after an elective abortion or a miscarriage. 3 to 7 days after the delivery, miscarriage, or abortion, there is still part of the tissue, part of either the placenta or the amniotic sac that's in there. It starts to decay. It's extremely vascular. That bacteria starts to leak up into the vaginal wall. It ends up causing a massive infection and they become extremely septic. We will manage them just like sepsis. The key is recent childbirth, recent miscarriage, recent elective abortion, now foul-smelling discharge, high-grade fever, signs of sepsis. Take them to the hospital. They're going to have to basically get their inside scraped and given IV antibiotics. If they're not treated, they can die from sepsis, and it can also create scar tissue and make them sterile and have fertility problems. Cystitis is basically a urinary tract infection. Burning when they urinate, difficulty urinating, hurts when they urinate, general supportive care. And we already went over PID and gonorrhea and chlamydia. Get out your ops packet. A quick 5-minute break, and we'll come back in and we'll finish. Ops isn't going to take but a couple of minutes. Because a lot of the ops we've already talked about. Plus, it's basically a study guide.
Is it a couple